Okay, and with that, we are live. Welcome everyone to Tea Talks. Once again, I am Peter from Total Health, and I'm filling in this week for my good friend and colleague, Sharon Gill. And today I am coming to you with the second of our two faculty spotlights this week. And I'm really excited today to be joined by Dr. Elyse Lauer from the University of Cincinnati. Welcome, Dr. Lauer.
Thank you, Peter. It's my pleasure to be part of Breast Cancer Awareness Month. So welcome to you and all who are listening.
Yes. Now, Dr. Lauer, you are Professor Emerita from the University of Cincinnati, and I know you play many roles up there, but you have also been director of the University of Cincinnati Comprehensive Breast Cancer Program for more than a decade. Mm-hmm. And beyond that, you are also one of our most prolific faculty contributors at Total Health. You've really been with us pretty much from the start, as I understand. And you and I first met, many years ago, a couple of years ago now, when I was still freelancing for Sarah at Total Health. We met at the Breast Cancer Expert Group meeting. And, that was such I think you'll agree, it was such a great experience in terms of getting all those, getting all the experts together and covering some topics. And I know we did a couple of publications from that subsequently. And, I really learned a lot from that kind of meeting with the experts. And when I had the unfortunate experience of my wife being diagnosed with stage 1 breast cancer last year, it was really, that knowledge was of great value to me, to help her navigate through, her diagnosis and treatment. And, of course, that's what we seek to do at Total Health with all our initiatives, and it's not the least of which is Tea Talks, which we're doing today, to inform and educate not only the oncology healthcare team, but also the individuals living with and after cancer. It's also breast cancer, it's also Breast Cancer Awareness Month, as you mentioned. So I think, the stars have aligned for our discussion today. And there's so much I'd like to talk about. You were actually a presenter along with Sherry Hughes from Cincinnati Cancer Advisors at our recent Seek Color workshop. In you kind of reviewed a number of some of the key aspects. We will be talking breast cancer today, but one of the other topics I know we want to talk a lot about today is disparities in breast cancer outcomes. And so I think your talk at the Seek workshop really touched upon that quite well, and really covered some of the main points where we are, we are seeing these disparities in breast cancer outcomes. And, it's to me like kind of a little bit of a dichotomy, because it's like, on the one hand, breast cancer really has been like the poster child for how a cancer can be effectively managed in terms of a public health problem. I mean, there's been tremendous advances in treatment and diagnosis and screening. And, that's really been observed over the last pretty much 20 to 30 years. And it's really been kind of an example of, when there's enough education and outreach, investment on the part of pharma in research and development of new drugs. And, certainly too, I think it's kind of, I kind of draw the analogy to prostate cancer in men. I think that women in general, I think they're just a little bit more aware of their health from a much younger age. So, it's kind of it's a great example of how that can translate into better outcomes. And, one of the things that strikes us, though, with that wealth of data that we have in breast cancer is that we do kind of see that unfortunately, the benefits haven't really been observed across the board. I mean, we know there are differences in outcomes, and specifically, we know that breast cancer mortality from breast cancer is unfortunately higher in specifically the black women population. And another thing that kind of struck me from your talk is that it wasn't always like this. Just I think back from like 1980, breast cancer outcomes were similar for Black women and for white women. And now, yet we're seeing these, those survival curves from breast cancer kind of shift. So I wonder if you could comment on that. And why do we think that is? I mean, is it all due to the fact that there's not equal access to some of these therapies and treatments?
Yeah, Peter, you've pointed out something that I think is really not well appreciated, and that's why I think the SEEK workshop was so helpful. So you are correct. There's been a lot of time, money, and effort gone into breast cancer research and treatment, and we have come a long way. I would never want to make us think that we're back to where we were with our mothers and our grandmothers' breast cancer. The outcomes are so much better today, and they're continuing to evolve. But it is clear to us over the last 3 or 4 years that there are some populations with breast cancer that clearly have a much better outcome. We know, for example, that white women with breast cancer in the U.S., the incidence is higher than in the Black population, but yet the Black population has a much worse overall prognosis.
Yeah.
And this is regardless of the stage. So if you match apples to apples and oranges to oranges, so a stage 1 in a Black woman versus a stage 1 in a white woman, you'll find that the outcome, even in the same phenotype, same stage, is much worse for our Black population. And I wish I had an easy answer for that. You're right.
That's the thing. I mean, there is so much. There's so much to think about in terms of what could be responsible, not only in terms of access to therapy, but I mean, clearly there are very likely genetic differences that we have yet to appreciate, because as we'll get into later, we haven't seen as great a representation in terms of research in breast cancer for Black women as opposed to Caucasian populations. So certainly there can be differences in the way the tumor interacts with the host, genetic factors, but also we have to think about modifiable factors, social determinants of health in terms of access to these therapies. So, I mean, where do you think the greatest need is there in terms of how do we start to solve this problem? Or it's a big problem. I mean, and there's so many factors involved. How do we start to address that problem?
Well, I think we have to tease out the different buckets of problems. And so first of all, I like to divide it into 2 parts. They're the biologic factors and the non-biologic factors. And we concentrated in the past in the disparity arena in the non-biologic factors. And that's probably, I wouldn't say it's a mistake, but that's things like access to healthcare, socioeconomic. This is very important. But remember that I said it's the same stage for stage. And early on, we tried to make sure women had equal access to mammography. That's still extremely important. But access goes beyond that. So after diagnosis, we have to make sure that women feel empowered to go forward with the treatment that's recommended. So there's access to making sure you can make it to your radiation appointment, access to chemotherapy, drugs, clinical trials. So the access is more than, gee, you got to get in there and get your mammogram. Not that I'm saying that's not important, it is. But we haven't focused on after the diagnosis, what happens to access. And that's something we clearly need to look at and to try to work on. But there are the biologic factors which you allude to, which I think are extremely important, and we don't want to negate them. And we're just starting to explore that. So if you look at the clinical trial participation in breast cancer, only 3% of participants in clinical trials are Black. And this is breast cancer clinical trials.
That's such a, it's just, people need to appreciate that's such a huge problem, because if we don't have that data, we really can't start to understand what are the contributing factors and why are we seeing these differences in outcome. I want to take a quick question from Sarah here. One of our program coordinators. Madison is saying hello, but I also want to take this. Says, Dr. Lauer, thank you for being with us. Can you talk about whether you have different conversations with women of different races about breast cancer, even if they have the same kind of cancer? And if so, how does that sound in clinical practice? That's a great question.
Yeah. So let me kind of lead up to that, because that's such an important part of the message that we need to get out.
Knowing that there's this increased risk, there may be this increased risk.
So if we look at the biology behind our breast cancers, we realize, for example, that women of color often have denser breast, and Black women in particular have a much denser breast tissue. And so we need to make sure that that woman has access to appropriate screening to have her cancer diagnosed as early as possible. We also know that women often will have, a Black race will often have triple negative breast cancers, those that are ER, PR, and HER2 negative. Those are more aggressive breast cancers and traditionally need to have specific drugs targeted to particularly, what may be going on inside the cancer. And we need to do genetic testings. We need to look at germline mutations because they are in higher prevalence in women who have triple negative cancers, say, compared to a woman who has a hormone receptor positive breast cancer. So it is key that we start to look more at the biology. So when we meet a woman face to face, we need to make sure that we have appropriately recommended to her testing for herself as well as on her cancer. Because we need to learn as much as we can about her chance of having an inherited mutation, such as BRCA1 or even PALB2 today. We know that even in early stage node-positive cancer, using some of our PARP inhibitors, we can have a much better overall outcome. And so we don't want to negate that. So regardless of the race, when you're diagnosed with breast cancer, we want to have the chat, delve into the family history. Make sure, even if there's no one in the family that has breast cancer or ovarian cancer, you still need to say, well, she's got a triple negative cancer. That by itself increases the likelihood that we might find a mutation. Offer her testing. And even if she says, doctor, I can't pay for this, that should be irrelevant. We have foundations. We clearly have many commercially available tests today that are very generous with their contributions. Do not forget to at least offer it to her, because that can open up a whole new area of treatment that may be very beneficial for her.
Now, I'm sorry, go ahead.
Likewise, if she has a triple negative cancer, we need to make sure that we've offered her testing just because of that phenotype. Yeah.
Right. Now, there's so much information that you just said, but I want to come back to something on the line of screening. You noted the impact of breast density, and this is something that you and Sherry Hughes talked about in your talk. You had a great graphic there, which kind of shows the impact of breast density, where you can't see the little snowball through the trees, through the snow-covered trees. And it's a very important point in terms of typical mammography for women that have dense breasts, such as it's known that Black women do have denser breasts. They may need an enhanced screening, which it's I believe that's with
MRI
or MRI. Okay,
right.
And that in a lot of states, including previously Cincinnati, I believe that was not covered by most insurance. And as I know from my wife's experience, some of these copays for the diagnostic mammograms can be quite expensive. That adds up. But you actually were involved in an initiative in Cincinnati to get women that have dense breasts coverage for this kind of enhanced. So I wonder if you could this enhanced screening.
Yeah. So as you pointed out, Peter, for years now, most states have had on their mammogram report that the density had to be reported. And so the report had to say, you have very dense breast, you don't have dense breast. It was on there, but we never knew what to do with it. It's like, ho-hum, okay, I have dense breast, but my mammogram is still read as normal.
Just to clarify, so the mammographer, the person who's reading the mammography needs to assess the density of the breast. That's something that everyone should know when they do the mammography.
That is correct. And that's not a physical finding, that's a mammographic finding. And we now know that virtually all states have legislation that mandate that they should have that on the report. So every woman, when she gets that normal mammogram, you know, when you have a mammogram, the first thing you want to know is it normal or not. It's like, it's normal, okay, I don't care. But you do care. The next step should be, what was my density? And if it says that the tissue is very dense, you should explore whether you should have what we call supplemental screening, which can be, usually it's best with an MRI, although there are some centers that will offer something called whole breast ultrasound. And we're still working out what's the best form of supplemental screening. Right now, MRI seems to be the best, because dense breast, as you pointed out, we used to think the problem was we just couldn't see anything because of the snowstorm, so to speak. But we know that just having dense breast by itself increases the likelihood of a breast cancer between 15 to 20%. Not just can't see it, it's the tissue density. And women of color have denser breast. So one of the things that I caution all women when they have their mammogram is know what the level of density is. Now, as you pointed out, part of the frustration would be, okay, you have dense breast. I don't know what to do with that. And nobody covers any additional screening. So I just say, okay, it's normal, and I go on. Well, we now know that many states, including the state of Ohio, have worked together to pass legislation that essentially provides coverage to any woman of any economic mean for supplemental screening if she is deemed to have dense breast.
Now, is there like a gradation? Is it like medium?
There are 4 levels of densities, and different centers will use different reporting mechanisms. But basically, we're not that creative. It's D1, 2, 3, and 4. So basically, D1 is, it's very fatty breast, and then D4 is very dense. And some of it is clearly in the eyes of the beholder, without a doubt. But between a 1 and a 4, virtually anyone can see the difference there. You get into a little bit of an argument between, say, 2 versus 3. Okay. But in general, it should be considered for supplemental screening. It's a chat to have. And as I said, we now have several states, although it's still less than half of the states in our country that will cover supplemental screening. And so I have to give a shout out to my patient, Michelle Young, who unfortunately was diagnosed with advanced cancer. And she'd had normal mammograms all along. It always said dense breast, and nobody ever really told her what that meant. And she never
asked the question. And she didn't know,
She didn't know.
Didn't know. Like you say, all you want to know is it normal or not?
Yeah. So Sherry Hughes also had dense breast and family history.
She investigated a little bit further, I understand.
Well, she knew. She was very proactive, and she knew I want supplemental screening. I want to do anything I can. But she was able to do any additional screening because of legislation that made insurance carriers have to offer it as part of their coverage. As I said, you don't have to have commercial insurance in the state of Ohio. Any woman that needs supplemental screening will have it provided to her for free. So it's very, very, very important that we know what our density is, because that by itself is an independent risk factor, and is one of the factors that can lead to delay in diagnosis. It'll perhaps be a more advanced stage because we just couldn't see it as well, or we didn't get to appreciate it as well. So that's an important modifiable lifestyle factor that we can all definitely think about.
Yes, and great that you were able to enact that, be a part of enacting that legislation in Ohio. I know you were part of that effort.
Well, it was funny because Michelle said, and Michelle's always been politically active, much more than myself, but she said, I have these Republican and Democratic Congress people. I'm getting them all in the room and we're going forward. Yeah. And she said, I don't care what party you're in. Breast cancer is an equal opportunity disease, and we all care about that. And she was exactly right. So it went through with no negative votes. So it was very, very important. Yeah.
Well, I'm hopeful that other states will follow suit with similar types of legislation, because it is so important, and it can be a barrier, again, another barrier to differences in outcomes. As you say, diagnosed later, you're going to have a different outcome. I also want to move into the issue of genetic and genomic testing. Let me just kind of clarify, when we're talking about genetic testing, like you said, Black patients are at a higher incidence of triple negative breast cancer. That usually sets off or if someone is diagnosed relatively early, that usually sets off an alarm for, hey, maybe there is a genetic component to this. We're not just talking about BRCA anymore, as we'll get into later, but it's kind of a red flag for maybe there is a genetic now when we're talking about that, we're talking about your DNA. So there needs to be, there are indications for genetic testing with specific clinical parameters are present, right? Like early diagnosis under 40, or triple negative phenotype, any other phenotypes that
well, I think, the number one reason why we offer genetic testing is family history. So, because you don't have to wait until you're diagnosed with the breast cancer. If you have a substantial family history for breast cancer, especially early age onset breast cancer, or ovarian cancer and breast cancer in the same family, or male breast cancer, these are conditions that increase the likelihood that there could be a genetic mutation in you, making it more likely that you could have cancer. And if we know that you've never ever had a breast cancer, if we know you have an increased risk, then we can again provide you better screening. We can recommend MRI screening, for example, rather than just mammogram, because we know MRI is a very sensitive test, but it can be helpful in that population as well. And clearly, after women are diagnosed with breast cancer, there are some professional societies, including the American Society of Breast Surgeons, that have advocated for all women, regardless of their family history or the phenotype of breast cancer, be offered genetic testing. And that's in large part because when it first came out, first of all, we only got information about really one gene, which was BRCA. BRCA1 and then BRCA2.
Now we have others.
We have many other susceptibility genes that we can easily screen for now. The other thing was it was very expensive, and then we didn't really know what to do with the information. You never want to do a test if you're not going to be able to act upon it. But that has totally changed. We now have extended panel testing that enables us to look at many, many other genes, and we are learning so much more about that. And when we talk about, to circle back to the whole disparity issue, we may find by doing more testing, we may find that there are alterations in other genes that we haven't even suspected yet, that may make it more likely that that woman could have a worse outcome or a better outcome. But we need to get the data. We need the information.
We need we need to know the differences between the non-Hispanic white and the Black as well. We may find differences there.
And other cultures as well. The Asian, yes, there are all differences that we need information. We are not all the same genetically, and we need to understand that. That's the host side of things. That's us as the host.
Now, the other, I just wanted to make this point. So it is very important, and some people don't know their family history. It is important to know your family history. Like my wife last year, when she was diagnosed, she opted for genetic testing because she was adopted. So she didn't have that insight. And, having breast cancer, okay, now should I worry about my daughter? Is there a familial risk? So, these are the questions that you want to ask when you have a diagnosis like this. And I know you're probably going to move into the whole issue of genomic testing, which is a different kind of testing. This is where we're testing your tumor's genetics, so the genetics of your breast tumor. And one of the things that we test for, and my wife had this test, and also Sharon, who is a survivor as well, had this test. There is a very commonly used test. It's called the 21 gene recurrence score, or Oncotype DX. It's very frequently used in the United States, maybe a little bit less so, but there are other tests as well that basically determine your prognosis. So I wonder if you could speak a little bit to those kind of testing.
Absolutely.
Why do we do that kind of testing?
Yeah, absolutely. So after your diagnosis, and I don't want to negate Sarah's question here. So after the diagnosis, you want to make sure you've done the appropriate germline testing and offering to patients. And then you want to look specifically at the tumor and try to figure out what about that tumor suggests to us that it's likely to recur. And if so, is it likely to be something for which we need to give chemotherapy and hormone therapy, or can we get by just with hormone therapy? And Oncotype DX has been around now for many, many years. We're into decades now, believe it or not.
It's most commonly used, I understand, in the United States.
Yes, yes. So if you look at NCCN guidelines, there are actually 4 tests that are approved to help us to talk about prognosis in early stage for the first 5 years. There are several tests that you can use. MammaPrint is another one that's commercially available. Oncotype came out first, and so we have perhaps more information about Oncotype. And the reason Oncotype is still the one that's used most in the United States, I think, is because it has a predictive feature to it that the other 3 tests do not have. And so the test is designed specifically to answer the question as to whether a woman who has an early stage hormone-dependent HER2 negative breast cancer, when I say early stage, that means the nodes are negative or up to 3 positive nodes.
Right.
If we do this test on the tumor, it will tell us the likelihood of it coming back in the first 5 years. And it will also tell us the likelihood that there's something in that cancer suggesting to us that she needs chemotherapy and a hormone pill, and not just a pill alone, not just a hormone therapy alone. Most women, as it turns out, do not need chemotherapy in addition to hormone therapy. So it spares the use of chemotherapy in a large group of women that we used to treat. In the 80s and 90s, before we had Oncotype, you would have this histology and you got chemotherapy. But, but we knew we were over-treating. Now we know that Oncotype can help us to figure out if chemotherapy could be beneficial or not.
Right. And I just want to clarify too, Oncotype is used in combination with our usual clinical factors as well.
Oh, yes.
To aid in that decision-making, because we're still looking at the tumor size. Has it spread beyond the breast? Metastasis? We're still looking at whether nodes are involved.
Right.
But, I know, and all of the data that assigns the relative benefit of chemotherapy are based on historical studies of women who took endocrine therapy for their hormone receptor positive tumors. Is that right?
Correct. And we knew we used to think that any woman who had a node positive cancer needed chemotherapy. We now know that's not true.
Right.
There are many women who can get by with just hormone therapy alone and don't need chemotherapy, but you have to tease that out. And again, this is a special population. So I think the key thing to remember is that, we are in an era of personalized medicine for cancer care, especially breast cancer care. And it's important that you not think about, well, gee, my aunt didn't need this and my cousin did need this. Where am I? You need to know specifically what's going on with your cancer and whether you will benefit or not. And that's our goal, is to try to sort through that. We're very fortunate. Not every tumor type has an oncotype. And as you pointed out, it's only those that are early stage, hormone receptor positive and HER2 negative, in which we will utilize this test, but it can help us. The other thing I want to bring up that we sometimes forget about in the world of genomics and genomic testing is that when you have that hormone-dependent breast cancer, we know that some women can benefit from only 5 years of hormone therapy. In fact, 95% of early stage breast cancer patients only need 5 years of hormone pills. But
right, and we know that endocrine therapy, most women are not a big fan of taking it for 5 years. I know the relative adherence to endocrine therapy is poor, and so a lot of people don't want to take it for more than they have to. So
right, that's absolutely right, and it's prevention. It's hormone, as a preventive therapy, and sometimes that's tough, especially if you're having side effects. But if you get a number that tells you this is going to help you. So when I talk to women, when we're at about year 4, we're through chemotherapy, or maybe a woman didn't need chemotherapy. Right. We're at year 4 hormone pills. It's like, I can't wait to be done. But at the same time, there's that little naggy thing in the back of your head that says, gee, maybe I'm one of those 5% that needs 10 years of pills. We have another genomic test called Breast Cancer Index, which is also in both NCCN and ASCO guidelines, that will tell us which woman is likely to relapse between years 5 and 10, That's very powerful. And which woman's primary tumor has a high H/I biomarker, suggesting that she would be the one that would benefit from 10 years of hormone therapy versus stopping at 5.
So again, that's hugely important because it has both the prognostic information as well as the predictive. Like, are you going to benefit from that extra 5 years that, you're probably not going to be happy to take?
Right. And not all women have side effects from hormone therapy. Many do. And I don't want to negate that, but many don't. And so you don't want to set somebody up for failure. And I think when you look at that and it says, gee, my chance of relapse between years 5 and 10 is, say, 15%, you may say, that's still way too high. I want to knock that down. And if I take, 5 more years of hormone therapy, it's going to be 8%. You're going to think about that. So again, you want to make sure that you figure out where you are, what are the characteristics of your tumor that will help us to best come up with a treatment plan for you.
Right. Yeah, I just want to add kind of my wife's perspective on this. We all have to, it's a personal thing for a patient. What is your recurrence risk? Some people are not happy with any recurrence risk. They want that as low as possible. Of course, we all do. But, some people will be happy with my chance is 6%, So I know my wife scored very low on the Oncotype score. So, her benefit from chemotherapy was obviously less than 1%. So definitely not needed. But, she was not wanting to take the 5 years of endocrine therapy. So, her risk was 3%. And the oncologist said right there, it essentially doubles the 6%. And she was fine with that,
And so, again, that's empowering. Yeah. That information specifically about your tumor is absolutely perfect because it helps you to make informed decisions. Yeah. You're the one that said, it's like buying insurance. How much car insurance do you need? Or how much life insurance do you need? If you're flying across the ocean, most of us don't double our life insurance policy, but somebody else might, So again, you have to look at the numbers as they relate to
again, part of that shared decision making, the way it should be. It's unfortunate when patient will go, oh, I'll just do whatever you tell me to do. It's like, I'm sure you don't like to hear that, because it really should be. It's your cancer. It's, and endocrine therapy also has risks.
Oh, for sure. Everything has a risk, but there are no guarantees in life. That's, anybody, even if you do absolutely everything, what we would consider, quote, perfect, unquote, we could still have a bad outcome. So, and that's just, and we have some people that do everything we tell them not to do, and they have a great outcome for decades. So, it's not a perfect society, but you just have to figure out what works best for you. What level of risk are you comfortable with versus side effects? It's very important. But at least today, we can empower women to partner in that decision-making.
Yeah, and that's so important. And I want to also, I want to kind of bring up, there is some evidence, I know with the Oncotype score in particular, that there is, there have been a couple of reports, but I'm thinking about one that appeared in JAMA a while back by Hoskis, that stating that, the Oncotype score, in fact, underestimated risk for Black women as opposed to white women. So meaning that women who were in that low range of not needing chemotherapy, I don't think it really changed the outcome of chemotherapy or not, but it tended to underestimate the risk in Black women as opposed to white women. I wonder if you could comment on that.
Well, I think really the bottom line is if you look at the people that comprised the Oncotype validation studies, they were mostly Caucasian and white. And this gets back to really one of the key points here, which is that we need to study more Black women and their cancers. They need to be in more clinical trials. They need to be more applicable to them. And so that we can change things. And it may be that has not been validated as to whether it's worse in Blacks or whites. And basically, it's probably a numbers game. We don't have enough Black women in the pool.
One of the things
we don't know for sure.
One of the things which I noticed in that study in particular, they studied like 86,000 women that were in the Oncotype DX SEER database.
Right.
And less than 10% of them were Black women.
Right.
So what that immediately I thought about is, are Black women even being offered this test at the same rate that white women are being offered this test? So Again, we don't have the data.
But again, that's back to we as care providers need to make sure that we are offering the standard, regardless of age, regardless of race. You have to look at it and make that recommendation. Now, that doesn't mean that, there aren't going to be circumstances in which somebody it's not fit for chemotherapy. You're not going to do an Oncotype because she's too fragile or has too many other comorbidities and could go through chemo. That's a different story. But you want to make sure that these women, regardless, have that capability, have it be offered. And the thing is, don't go into it thinking, well, this is a tiny tumor. She works full time. She's a single mom. She's got 2 kids. She takes 3 buses to get here. It's going to be too hard for her. She'll never be able to do it anyway. That's not right. If she needs to take chemo, we need to make it so she can get chemo. And if that means, we need to think about, social services or, putting together a system of friends and support services, we need to offer that. We need to work our way through that. But for sure, we need to gather the data. That's the most important thing.
I do want to take a quick question from Sarah here. It's on this Oncotype issue. It says, Dr. Lower Nathalie Johnson, a renowned breast cancer surgeon, highlighted a JAMA article that found that Oncotype could be less accurate for Black women. The rationale is that Black women, like you say, were vastly underrepresented in the clinical trial, leading to lower accuracy, and that the test may need to be recalibrated differently to account. Do you feel comfortable applying the results to all populations or counsel the patient on this?
So, Sarah, that's a great question as always, but the reality is this is the best we have in this space at this time. And Dr. Johnson, I think her feeling is that because of the underrepresentation, she, like most of us, we're not sure of that, but it's the best we have. So I tell people, based upon the data that we have available, we think that this is the best way to make decisions. Regardless, I clearly feel it's better than us looking at just standard clinical pathologic features. I mean, I think that's way, way, way too much, because in that setting, everybody would have gotten chemo. And I think that really is not correct. Now, going back and recalibrating it, I don't think we know the answer to that. And I think we have to be very careful about that. If you don't know, you can't, it's hypothesis generating. And I think that if companies see that that's a need, they can go back and, figure out if recalibration is necessary. Maybe it's the wrong gene set. I don't know the answer to that.
That's a great point too, because, it's the same for all of these tests, really, because all of them were validated in largely the same populations, which are European Caucasian populations. So it is the best that we have for estimating, and we're not going to have more. I don't think we're going to see more clinical trials to revalidate these tests. But
the problem is the validation of these all of these initial studies were studies that had been randomized phase 3 studies way in the past, and for which you had to have follow-up. You have to have 20, 30 years of follow-up when you're talking about a 5 and 10 year outcome. You need a long time. So even if we came up with a new gene set today and we wanted to apply it, it would take years and decades before we would have the correct information. Now, that doesn't mean we shouldn't strive to do that. Don't misunderstand me. I think that there are some potential shortcuts that you can think about, but it's still going to take a long time to get the correct data. But part of the problem is in our tumor banks, we still do not have the appropriate representation. Although we have many Black cancers, we do not, and I think this is true regardless of tumor, not just breast cancer. And the same can be said for other populations, the Asian population, which we're seeing more in our country, the Hispanic population. They may have very different genes, and we need to start learning about them. And we are. That's, the burgeoning fields of genetics and genomics are enabling us to look at this more. But participation in clinical trials is key here. So I would not throw out an Oncotype. I would be very cautious, and I would not do that. I would not say it doesn't work. I would say it's our standard of care now. Just like everything in medicine, standards of care evolve as we gain more data and we have more clinical trial information. But again, I think the push is find a good study or a good data repository system that you're comfortable with, and try to embrace that. That's how we really push the science.
Right. And, I wanted to bring up that. Well, I know our time is go running long here, but you've raised this before. And the whole thing about the lack of clinical trial diversity. I know there's again, so many factors that are contributing to that. But, one thing which, I learned myself about in the past year is that there are some real historical injustices that occurred in this country, and it didn't happen too long ago. So, we're talking about only a generation ago that, there were some real injustices that have resulted in just a kind of a distrust in the medical system, which is a big part of the problem. I wonder if you could comment on that.
I think that's the part that hurts us the most. There's no answer for it, to be perfectly honest. Especially the way the world is today. There's a lot of difficulty happening. But I think that, when I talk to Sherry and others, I think the biggest thing is that we need to win trust. And I think perhaps a way, and it's not necessarily the best way, but a way to help with that is to partner better. And when you design a clinical trial, have people on the design team that represent the population you want to study.
Yeah, that's so important.
And have in your system, once there's a good clinical trial, because they may see biases in a clinical trial that we don't see. And this could be, it'd be like me designing a prostate study or something. There may be things I don't see as correctly as I should. And so I think it's important. Don't put in bias if you don't have to. There's always going to be bias. We all have some bias.
Right.
But, try to put people on the design team that can at least minimize some of the biases that we may have. And that gets into access to, care too. Don't design a study where you have to have blood draws every day. That's not feasible. It's fine if you want to do that for a group that you're going to provide transportation for. Perfectly fine. Nothing wrong with that. And that's an important. But, if you're talking about the average mother that's trying to work and raise kids, that's not going to happen. The first thing she's saying, well, if I can't have my blood drawn on Monday, Wednesday, or Friday, what happens? And the coordinator is going to say, well, you're out of the study. Well, that's not good. We've got to work our way through that.
Yeah, and I thought about something from one of our other workshops. Someone raised the issue of using telemedicine now, which everybody uses that now. It's like, why can't you, if you're on a check-in via telemedicine, especially if you're on the control arm of the trial, utilize that more in the trial design, as you said.
Well, yeah, but there are some issues with telemedicine. Telemedicine saved us during the pandemic, but you need a physical exam usually in breast cancer studies. You can't do that on telemedicine. So you can do that to a point. So in rural areas in which it's just, you'd have to helicopter somebody in, that's not going to work.
Yeah.
So I think there are clearly times and places in which telemedicine can take over, but there's still going to be times when you need blood. You need to examine the breast. You need an ultrasound to see what's happened to the tumor. So we have to be practical. You don't want to design a study in which, you're not doing the appropriate test as well. So I think that's a good thing. The other thing that I want to stress, and this gets back to Sarah's first question, which is, what do you tell a woman when you're first diagnosed? What kind of tests should she have done? And what you want to make sure you recommend to her the state of the art. But your healthcare team, your nurse navigator team, your clinical trial team, and your coordinators, your nurses in your office, your medical assistants, your scheduler, everybody from soup to nuts, you want to have them feel comfortable and to make it a team that represents the people that you are taking care of.
Exactly. Yeah. It's important. The diversity in the workforce. That's so important.
Yeah, we need such diversity. It's so very, very key. Yeah.
Yeah, and I do like the initiative. I believe it's the NCI is now requiring. Some of these funding agencies are now requiring that if you're going to be running a study, you have to be representative of the population that you serve, which is only right. Or at least the should be representative of the United States population in terms of percentage and makeup of the population, for sure.
Yeah. But I think that, we started talking about why is there that 14% worsening in survival in our Black patients, stage per stage, compared to our white patients that we didn't have 40 years ago. Part of it is that I think that clinical trials, because they've been primarily focused on the Caucasian European population, We have much more information about those women's tumors than we do other populations. And we need to catch up because we are using what's in those clinical trials, not just the BRCA gene and the PALB2 gene, but we're using all the ESR mutations and the PD-L1 mutations to guide us. And maybe
there may be specific treatments that are better suited for treating
absolutely,
women.
absolutely. And we need to look at that. We need to know. I suspect that they're not the same, and we need to be able to figure that out. Yeah.
Well, Dr. Lauer, we have covered so much ground today. We've so appreciated this, but we like to, coming to the end of our time here, we like to kind of give the guests the kind of the last word. And the show is called T Talks, which our founder Sarah is kind of a play upon the T cells, which are our cancer fighting cells. So we like to leave everyone a little bit uplifted so that our T cells are stimulated to fight our cancer if we have cancer. So I will give you the last word in saying, I know we recognize that there are these disparities in outcomes, but on the other hand, it is a very encouraging time in breast cancer, especially. So what are you excited about in the field, and what further advances can we look forward to?
Well, first of all, Peter, thank you, Sarah, and the whole Total Health team for inviting me today. And as you predicted, it buzzed by. The time just flew by, which we knew it would. But, this is Breast Cancer Awareness Month. And although we talked about some sobering statistics, the reality is that we are doing better. And this is the most exciting time to be involved in the breast cancer space. There's no two ways about it. The genetics and the genomic space is enabling us to look at tumors, to get more targets, to get more therapies that will hopefully improve outcomes. And they are improving outcomes already with less toxicity. The old-fashioned chemotherapy is not used like it used to be. We're now in the world of ADCs, antibody-directed conjugates. They're very, very different. And they're helping us. It's a new drug delivery system that is helping us dramatically to get those drugs to the right targets and to work with our environment. So it's a very, very exciting time. I will just say that in the last couple of years, the two areas that I am so impressed with, one is the treatment of HER2-positive brain mets. We've gone from women living for weeks when they were first diagnosed to 2 years.
Wow.
That is phenomenal. We want 20 years. We want to be pigs, but we're getting there. And again, that's understanding that pathway and getting better treatment strategies. And the other is triple negative. I can't tell you the number of women who will come in and say, oh, I've got that horrible triple negative cancer.
There used to be nothing for it.
Yeah,
now we have options.
That's right. It used to be that we just put everything that wasn't hormone receptor positive or HER2 new driven into this basket and called it triple negative because we didn't know what to do with it. We now can tease it out. In the last couple of years, we've come up with something called HER2 low, which has a specific drug, TDX, that we can use to treat it. We have sacituzumab govitecan for triple negatives. Who would have thought? So these are such exciting times, and there's going to be more. I just want to end by saying if I had a crystal ball, I would predict that pretty soon we're not just going to be looking at our tumors only and their genomic contents. We're going to be looking at us because we methylate and we do all kinds of things differently. And that helps us to know how much drug to give. Somebody may need more, somebody needs less, somebody needs a whole different category. So I think one of our next big strategies is going to be looking at us as people and matching our genomes with our tumors' genomes.
Yeah.
So the sky's the limit.
Brings up the prospect of AI and
yes,
putting all that stuff together. That's going to be, I think, a real revolution when we start. Well, Dr. Lauer, it has been such a pleasure talking to you. So much information for our listeners, and I hope we will see you again. Thank you to everybody in the feed for participating. Sharon Gill will be back on Monday with Tea Talks. Dr. Lauer, I'll ask you that you just hang out for a couple of minutes after I end the stream, and we'll talk some more. But everybody else, thanks so much for watching, and we'll see you next time on Tea Talks.
Thanks.
Bye-bye.